a lot of material we're going to do. I'm going to do some art therapy here in terms of the heart. Coronary artery disease, myocardial infarction, we need to know all about that stuff because it is the #1 killer in America. So it's definitely going to be on your NCLEX. It's definitely going to be on, you know, future exams, pharmacology. It's heavy. So, let's go into this. All right, so coronary artery disease, okay? This is the #1 cause of death in America. We have diabetes mellitus as the #1 risk factor. So if someone's got diabetes mellitus, they will, God bless you, they will do a lot of workups on them in reference to the cardiovascular disease. They want to make sure the HDLs and the LDLs and triglycerides are all up to par or under par, whatever that is in those terms, because that is the #1 risk factor. Smoking is the #1 preventable risk factor. Okay? Upset it down. What's happening is that I taught or you read about the atherosclerosis. What's happening here is that the coronary arteries, the blood vessels that lead to the muscle of the heart, the myocardium and endocardium, the coronary arteries are narrow, usually due to some sort of atherosclerotic plaques. It's the leading cause of ischemia going to the heart, and they will get any kind of ischemia to the heart. We call it angina. We'll talk about that. It can also lead to, if it goes further and it's long-standing, then we actually will call it a myocardial infarction, where necrosis actually occurs. Now, 50% of people who have a myocardial infarction do not have any risk factors. So these are the people that, like, they have a heart attack, like, wow, this person, you know, he's been eating the right foods, he goes to church, he doesn't smoke, and he has a heart attack. Well, he had no risk factors for the myocardial infarctions, and there was no prior symptoms of having coronary artery disease. It kind of sneaks up behind you. So this is why we try to do some preventative medicine, and we do, you know, check the blood pressure, listen to the heart on annual exams. Okay, but that's a big point over here, that 50% of people don't have any risk factors or prior symptoms of coronary artery disease. So let's talk about angina pectoris. This is basically chest pain that a person gets because ischemia to the heart. Now, this is not a total blockage. If you have a blockage in the coronary artery, that's going to cause an infarction. But if you have a decreased amount of blood flow to the heart muscle, then we call it ischemia, and we call it angina. And it will cause, it can be caused by atherosclerosis, that's the most common cause, but you could have a blood clot there also, thrombosis. Or it could have been a thrombosis from some other place and it became an embolus and went into that spot. Or it could be just a vasospasm, where the coronary artery just spasms on itself. All of those is going to cut down on blood flow to the heart. And when I say blood flow to the heart, not the heart chambers, we're talking about the muscle of the heart. The muscle of the heart is tissue. It needs oxygen. It needs glucose. So what I'm talking about is the coronary artery gives blood flow to the heart muscle. And this can occur, angina can occur with or without a myocardial infarction. Okay? So this typical case of someone who has angina is they have chest pain. And chest pain they usually refer to as a squeezing or a tightening in the chest. And it's due to this inadequate blood perfusion to the heart muscle. A lot of times the chest pain is there, but then it radiates closer, more or less on the left side, because the heart kind of leans to the left side, but it doesn't mean that if they have pain on the right side that's not a heart attack, right? So they are angina for that matter. So they usually have chest pain that radiates usually to the left shoulder, to the jaw, to the neck area. Okay. What they tend to do for angina is give nitroglycerin, a nitro pill. And what they do is, nitroglycerin is a vasodilator. So when you take this, and they usually put it underneath the tongue. Underneath the tongue, if you lift it up, you can actually see your veins right there. So there's a very little amount of tissue between the the oral cavity and the vein. So you actually could put it, let me just finish here. So you can actually put a pill underneath there, and it'll get absorbed very quickly. Nitroglycerin is a vasodilator, and it actually will vasodilate all your blood vessels, including the coronary arteries. So once it opens it up, the ischemia should go away. pain does not go away, the chest pain does not go away, think myocardial infarction. Okay? Not all the time, but you got to think. Usually the nitroglycerin will actually dissipate that chest pain.
Is that why they make certain medications like CORONARY and certain things like that dissolve in the especially when people have seizures?
Yep, and underneath the tongue. Fast absorption. We're going to talk about aspirin too, about myocardial infarction, what that's going to do if you put it under the tongue. Fast absorption goes that way. Okay? Yep, exactly right. So we have three types of angina. We have stable angina, which is basically you have this chest pain during exertion. You're lifting up a wheelbarrow, or you're lifting up a table, or you're running, and you get this chest pain. But then while you rest, the pain goes away. That's what we call stable angina. Okay? That's the most common type. Then we have unstable angina. In this case, they have chest pain that is, you exert yourself, lift up a wheelbarrow or table, you feel a chest pain, and then you rest, and the pain is still there. Okay? About 30% of these patients will have a myocardial infarction within 3 months of that chest pain. All right? It's usually a very ominous sign that this person is going to have a myocardial infarction pretty soon. In this case, it's usually not due to atherosclerosis. It's usually due to either thrombosis or vasospasm or embolus that got there. Okay? Then we have another type of angina, which is called Prinzmetal's or variant angina. And what this is that they get intermittent chest pain with or without exertion. So you can have it during rest. So you're just watching the football game and everything is happy and the team is winning that you want. And all of a sudden you got this chest pain. Or it could be that, you're throwing a football and running and you got the chest pain. Either way, this is usually due to vasospasm as opposed to atherosclerosis or any kind of thrombosis. Okay? Now, let's talk about this big one now. Myocardial infarction. This is cardiac arrest, a heart attack, all right, an MI. A myocardial infarction is necrosis of that muscle tissue because there's some blockage. So it's not ischemia, it's not a decrease of blood flow to the heart muscle. It's actually blockage of blood flow to the heart. So now it's not getting any oxygen or nutrients and so forth. Okay. The size and the site of necrosis depends on which coronary artery or what branch it comes from. So now you have to go back to anatomy to figure out which, the branches of the coronary artery. They're important for you to know. Like I said, this stuff you definitely need to know because all this is going to be on all your future stuff. This is number one killer in America. We do have some people going through what we call a silent myocardial infarction. This is where they have a heart attack or a myocardial infarction, and they don't feel any pain. About 20%, this is about 20, it's very scary. This is about 20% of MIs do it this way, and they don't feel any pain.
So how do you know?
But that's what's difficult. Yeah, they had a heart attack before, and they didn't feel it. It didn't cause them to die, but it caused them to maybe they hear a heart murmur. And we'll talk about complications of heart attacks. I mean, death is the number one. One of the things that they actually die from. Or I'm sorry, death is one of the complications that will cause this, but not all the time. So 20% of this we usually see it in diabetics. And that's the reason, we talked about it before, the microcirculation. When you have a lot of glucose in the bloodstream, the small vessels, the small blood vessels, are going to get clogged up with all this extra glucose. And when it does, for the small vessels that actually feed into and give the nutrients to the nerves, now you have less blood flow going to the nerves. So then the nerves start dying down. And that's why we see, as we explained, that people with diabetes, they don't feel much on the feet because the nerves that go to the feet have all died. They have that peripheral neuropathy or diabetic neuropathy, right? So because of that, they usually don't feel any pain. Sometimes it might not be a very hard pain. It'll be something like indigestion. So any diabetic that feels as though they have heartburn or indigestion, think myocardial infarction. It may just be indigestion, but because their pain is deadened a little bit, it's not all there, something like reflux disease, or at least the symptoms of reflux disease, might be a heart attack in a diabetic. That's why you got to think that way. So the different sites for myocardial infarctions. Now let's talk about places. So the left ventricle is the most common site, okay, more than the right ventricle. Large infarcts affect the interventricular septum and the right ventricle. The anterior infarcts are usually larger and have a worse prognosis than posterior infarcts. Okay, just to give you some tips on that. So the three most common sites, and you should know these over here in terms of like blood vessels or the branches. The most common site, 50% of the time, is going to be the anterior descending branch of the left coronary artery. Where does that give blood supply to? It gives blood supply to the anterior left ventricle and the apex of the heart, the pointy part of the heart. We also have the second most common place is just the right coronary artery. That's about 30% of cases, and that supplies the posterior aspect of the left ventricle. And the least, or like the third one that's most common is the left circumflex branch of the left coronary artery. The left coronary artery are both of these over here, and that supplies the left lateral ventricle. And I found this actually these pictures over here, which kind of shows you where the anterior descending branch is. If there's a blood clot over here, and then if you take a cross section here, you can actually visualize where that actually gives blood supply to. It's a little bit easier for you to visualize there. Same thing with the right coronary artery and the circumflex branch of the left coronary artery. So it makes it a little bit easier to visualize there. Okay? Now, on this picture here, this is actually showing in a sense of how deep the necrosis would occur. So here's your myocardium over here. This will be your cavity, whatever it's going to be, let's say the left ventricle. So here's the cavity. So the lining of this cavity is going to be endocardium. Here's your myocardium, and here's where you're going to be seeing the coronary artery, which is outside of the myocardium, right? So if there's a blockage over here, normally, if there's no blockage there, we're actually going to give oxygen first to these areas here closest to the coronary artery, and then further you'll be able to get it later. So if there's some blockage over here, the area that's going to get mostly affected is going to be the further area. So the endocardium is the area that's going to get affected first, and then gradually it's going to go closer to where the coronary artery is. Does that make sense? Right? It's going to be furthest away, because that's where, all this area, as it's traveling that way, this is going to get oxygen, but then we're losing all the oxygen by the time you get deeper in this. So it's the endocardial area that's going to be affected first. A severe blockage will have what we call a transmural through the whole myocardium, and those are pretty severe. Okay? So we have a differential diagnosis, DDX, it's differential diagnosis of chest pain. These are the things that are coming into the hospital. If someone has chest pain, the first thing they're thinking about is heart attack. So I guarantee my tests and the future exams, NCLEX, these are the people that are coming in. So you need to know about differential diagnosis of chest pain. It's a very common ailment that people are coming in for. Sure, if someone comes in, think heart. So do an EKG, ECG, see what's going on with that. Suspect in men greater than 30 years old or women at 40 years old that this could be a heart attack or angina. It could also be pneumonia, pulmonary embolus, pericarditis, rib fracture, you fell down, okay? Also, this one too, most people don't know about. This is a fairly common thing, costochondritis. Costo means ribs, chondro means cartilage. So this is inflammation of the cartilage that is going to connect the ribs to the sternum. And that usually can get inflamed also, and that's a common cause that people just don't think about. It just happens, actually, just walking a certain way. We don't know, it's like idiopathic, it just happens. And there's not much you can do except probably give some Motrin or some kind of ibuprofen or something like that. But why is it important? Because it's a differential diagnosis for chest pain. If someone at 40 years old has chest pain and it's not this, we could say it's this. You always expect the worst and then gradually go down to these easier things or these more simple and benign things. You can also think of esophageal spasms, aortic dissections, gallstones, gastric ulcers, etc., etc., etc. All right, so it's just as we go through, if you see something as we go through diseases and you see something like it can cause chest pain as a symptom, then make sure you write that down because you're going to want a whole differential diagnosis of that. Okay? So what do we do to rule out or to identify people with myocardial infarction? Well, we got to do EKG, right? ECGs happen. So we do that as an immediate test. This will help with the plan. What should we do? All right? Should we put in a catheterization going in, put a balloon there? We'll show you that in a moment. Angiography. Should we do thrombolytics? This should really say thrombolytic medication, not antithrombolytic. This doesn't make sense. It's kind of like a paradox. So I'll fix that. So that helps with the plan on this. So there's 3 classic signs that you will see on an EKG that's very typical on here. Now, sometimes these signs don't happen until an hour after the chest pain or an hour after the infarct. So you might not pick this up right away. And a lot of this stuff will go back to normal if someone had a silent MI. They didn't know they had it. So they don't see if there's anything, they wouldn't pick this up if, let's say, they have an EKG, just a routine one 3 months later. You won't see this stuff, okay? You may or may not. So what's happening here is that we have an inverted T wave, and that's a sign of ischemia. And I'll show you what this looks like. An elevated ST wave, and that's a sign of injury. And you can have these deep Q waves, and that will be a sign of infarction or necrosis. So what does this look like? Okay. This is what it normally looks like. Here's your P, Q, R, S, T. Okay? Here's an inverted T wave. That's a sign of ischemia. Now, I do want you to understand that this is also signs of other things, okay, which we won't go into. But inverted T wave doesn't just mean ischemia. But when you if you had a normal EKG before from a year ago, and now he has inverted T waves, and he comes in with all the signs and symptoms of like angina or something, you're putting it all together. But a lot of times, I even have an inverted T wave. So a lot of times, this might just be an idiopathic thing, okay? But it would be nice if you had like a baseline before so you could compare it. So there's an inverted T wave. You could have this elevated ST wave. See it? How it goes up like this? That's a sign of injury that happened over there. And then if you have these deep Q waves that come down like that, that's definitely an infarction or necrosis. Now, a lot of times you could have just isolated areas over there, or you could just have it could be all together. You got the Q wave, yes, elevated ST wave, and you got the inverted T wave. All right, it could all be. What did I say? I say Q wave, right? The deep Q wave, not the QT. Okay. So yeah, a lot of times, if they see this, they always go to the nursing students or the medical students, and they say, "What do you think of this EKG?" Like the head nurse or the doctor says, "What do you think of this EKG?" That's classic that someone just had a heart attack. Classic. So if they show you that and you say, "Oh, I see the elevated ST wave, I see the Q," it's heart attack. A lot of them like to just ask because that's just typical. Okay. Questions on EKG findings? All right. So we can also do, besides doing serial EKGs, and like I said, these EKG findings might not happen until, let's say, an hour later. Okay? We don't know. It could be a few minutes late, it could be just instantly, or it could happen later. So we also like to do other tests. Other ones we do is serial blood or cardiac markers. So this is an immediate test to do when a patient comes in. All right? It's important. It's an important test to differentiate chest pain. I mean, if these are not elevated, then chances are that person didn't have a heart attack. You said, I mean, and we're going to go into what those are. So that'll help over here. It'll tell you the size of the myocardial infarction, and it also helps with treatment plan. Because dead cardiac muscle tissue releases certain enzymes. We talked a little bit about this, not so much about heart and muscle, but we talked about this with certain, God bless you, certain cancers release cancer markers, right? CEA and so forth, right? Alpha-fetoprotein, that kind of stuff. So a lot of tissues, not just cardiac muscles, the brain, a lot of places release certain enzymes or proteins when they get damaged. Okay, so the amount of the cardiac muscle or the cardiac markers is proportional to the size of the myocardial infarction. Okay, so we check these levels even if the EKG is normal. Like I said, sometimes EKG is normal and they did have a heart attack. It just didn't show up just yet. Okay, so we need to check those. So these are the markers you should know. Okay, creatinine kinase. Okay. Now, creatinine kinase comes out of the brain, the skeletal muscle, and the cardiac muscle. But we do look at something called CKMB. So it's creatinine kinase MB. I don't remember what MB stands for. But this is more specific to cardiac muscle. Okay? It's sensitive, but not specific to MI. In other words, if there's some damage to the heart, that these enzymes will get released, but it could be during an injury. It could be during ischemia. So it's not specific for an MI. It is specific coming out of the heart, but it's not going to help. I mean, it's sensitive. If you see something if you see these blood markers that come out, you know something happened to the heart. We just don't know what. So we say that it's sensitive, but it's not specific. And these go down to normal levels in 2 to 3 days. So if a patient says, you know what, I had some chest pain, 4 days ago, and we check something, these are not going to be up by now. Okay? So that's one test. We have another one, we have cardiac troponins. And they're more specific than the creatinine kinase. There's a couple of different types. I won't ask you about the different types. I just did that to be complete. But neither type is found in healthy people. So this is more specific. If we see this up there, if we see it in the blood, we know that the person had a myocardial infarction. Okay, it's very specific. It would not be in a healthy person. And they do serial amounts. So this actually, the normal levels will fall back in about 7 to 10 days. But if we see it creeping going up, so we like to do this like every 8 hours, and this one's, I forgot how many hours this is. So we like to do a serial amount, like repetitive, every so many hours, and we see if it's getting better or getting worse. So we do these tests over here. We can also do coronary angiography, and this helps determine the site and extent of the coronary obstruction. We're going to put a catheter into the coronary artery and see what's going on. We're going to shoot a dye in there, and we can actually see if there's any blockage. Sometimes we'll use this to help with diagnosis or with therapy. And I'll show you that with a balloon and stuff. Okay? Now, complications of MI. You need to know all of these. Okay? Very important to understand these over here. So, first one is you get cardiogenic shock. That kind of makes sense. If the heart is not going to pump properly, their blood volume is going to go down, and that's what will happen over there. You have arrhythmias. Arrhythmias is irregular heartbeats for whatever reason, and we'll talk about those later on. 90% of MIs do get arrhythmias, and this is usually what they die of when they come to the hospital. If they die en route to the hospital, it's because of an arrhythmia. Okay? Some may be temporary, some may be fatal. They may also get valvular dysfunction. If the coronary artery gives blood supply to a papillary muscle, and that connects to the tricuspid valve or the mitral valve, then that valve is not going to work. So that's what's going to happen there. We usually have about 30% of people with myocardial infarctions end up with mitral regurg, and we'll talk about regurgitation. They could also have the myocardial tissue just rupture. All right, there's so much blood that's in there, and it's so weak it can burst open. About 1%, and that's just instant death right there. Okay, some of them might just balloon out. Some of the let's say the left ventricle starts ballooning out, an aneurysm, and we see something like that. Okay, And some of them will have these mural thromboses. Basically, you have in the coronary artery, it's going to shoot off an embolus. And that's where this is. About 20% of MIs actually do this. And what we're afraid of, it's going to actually shoot inside the brain. Okay? That's what happens there. Oh, and ischemic cardiomyopathy. We'll get into what these cardiomyopathies are in a little bit. But basically what's happening, it kind of makes sense. If you have less muscle, if you get muscle that's getting less blood flow, that means that muscle is not going to squeeze properly. So therefore, you have less effective pumping of the heart, it's going to lead to some sort of heart failure. Okay? We have about 60% of people with myocardial infarction having it this way. So you should know all these complications of heart attack. You know. All right. So so this is a picture. It's like when I was talking about here, where the papillary muscle ruptures, it can actually cause valvular dysfunction. This picture here, here's the papillary muscle, and it's attached to, let's say, this could be the tricuspid valve or the mitral valve, but it can actually rupture too, where it's split up, and now that muscle is not, or I'm sorry, that valve is not going to function properly. So how do you treat people with myocardial infarction? Okay. Well, the first thing you do is you admit them. All right. They're going to have to go to an ICU, intensive care unit, or a cardiac care unit, CCU. All right. You have to do that. Give them oxygen. Okay. Aspirin. We learned that through studies that if you give them aspirin immediately, okay, that cuts down mortality rate by 25%. And they want them to chew it. Why? Again, for getting fast absorption underneath the tongue. So if someone is collapses and you do the ABCs for CPR, okay? If the heart is beating and the lungs are you've got them breathing, you've got them you got the heart beating. If they're awake, give them aspirin. Go into go into her purse, and maybe they have aspirin in their purse. Just let her just chew an aspirin. Go into the medicine cabinet. This will, I don't remember the exact hours. I think it's like if you do this within 4 hours of the heart attack, this is when it works. If it's less than, I'm sorry, if it's more than 4 hours, then this 25% gets less and less and less. You want to do it immediately before the ambulance gets there and stuff. But this actually does it, okay? If the person's still unconscious, have someone in your family crush up like an aspirin, put it underneath their tongue, okay? So it's things like that. This will actually save their lives. One in 4 people who have myocardial infarctions, if you do this, you can actually save their lives with that. Okay. You might have to give thrombolytic medications. That'll also decrease the mortality. If they have a clot there, you can break it up. Again, you would want to give this in the first 12 hours of the pain. Beta blockers. Not so much I want you to know this, but beta blockers, you need something that they're going to decrease the heart rate, because you don't want the heart to be exerting itself when you just had a heart attack. So lower the heart rate, less than 60 beats per minute. This will decrease mortality. Give them nitroglycerin, as we talked about before, but don't give it with Viagra. What I mean by don't give it with Viagra, if the person, now think of what's happening. Person just, let's say someone who's 68 years old, got the Viagra, all right, has intercourse, that's exerting themselves, right? Has a heart attack right there. Okay, so you would think, you have to always ask, what was the person doing before this happened? Sometimes, there's an extramarital affair, you might not want to say anything, but we need to know, not to be judgmental, but we need to know, is there a possibility they used Viagra? Viagra is a vasodilator that is going to go specifically to the blood vessels in the penis to vasodilate them to get more blood flow there, so it would cause an erection. Okay, so people have erectile dysfunction. But it's a vasodilator. So if they use Viagra in 4 hours, within 4 hours of coming to the hospital, they already have a vasodilator on them. Now you want to give them nitroglycerin, you're going to give them a double whammy of another vasodilator. But it goes throughout the whole body. So they will go into hypotension, a pretty severe case that will make them unconscious. Okay, does that make sense? So it's not hypertension, it's hypotension, because you give them a double whammy of the vasodilators, okay? You give morphine for pain, and you also can give heparin to break that up. Now, I just want to say to you, I know people probably want to put an X here, but I'm not going to ask you anything on here, okay? The thing is, I don't want you to put X's, but I just want you to understand that you need to worry about your future. You're going to be, you're going to be nurses, so you need to know everything about myocardial infarction. Write in your notes and build on your notes. You have cards for myocardial infarction, and you do pharmacology and treatments. This is all going to be on your NCLEX. I guarantee it. That's the #1 killer in America. They will ask you. All the following will be used for myocardial infarctions except that kind of stuff. Make sure you know that stuff. I won't ask you this stuff because it's more like medical and treatment. It's just too much for this. But I wanted to definitely start you up on there so you get the ball rolling. Okay? Yeah. Okay. So treatment used in angioplasty. Okay. The word angio means blood vessel. Plasty, we're going to reconstruct it. We're going to change the way it's shaped. That's what plasty means, right? Plastic surgery, right? You're going to change the way certain things. Rhinoplasty, I'm going to do a nose job, right? I'm going to rearrange that. All right, rhino means nose. Kind of a weird thing, think of rhinoceros, but either way. So yeah, I had this kind of stuff in here in terms of when we dealt with blood vessels. So you could actually do PTCA, which is a catheter that comes in and kind of acts like a roto-rooter. It's going to remove the plaque that's causing the blockage. We can also put a balloon there, and I'll show you what that looks like. It's going to actually open up the blockage that's happening there. Or we can actually put a stent there. So, and I kind of showed you these pictures here in these blood vessels. We put a catheter in, and at the end of the catheter, when we get to this block, and you can see this with over the angiography, you see how far you go, and you can see where the blockage is, and then it blows up, and you can actually push that fat off to the side, right? Or you can put a stent there. And a stent, you put the catheter into that area, and then the stent opens up. It's kind of like I've seen, I don't know if you've seen with the carnivals, they have that little, they call them the Chinese finger locking things. You know what I'm talking about? Yeah, Chinese handcuffs. You put your fingers in there, and now you can't get them out. It's that kind of thing. But it opens up, and that stent does stay in there, okay? And it kind of pushes the plaque off to the side. So that opens up. All right. Now we could also do open heart surgery, and that we're going to be doing, let's say, what we call it a CABG, coronary artery bypass graft. We call it CABG for short. And what we're doing is we're putting a bypass. So if there's a blood clot in a certain area of the coronary artery, well, we're not going to do anything with that blood clot. We're now making a bypass, and I'll show you what that looks like on the next slide. But the bypass can be the long saphenous vein. If you remember, it's from the leg. So it's not uncommon to see someone with open heart surgery, and there's a big scar over here. They open it up and do whatever they need to do. But they may also have a scar from the groin all the way to the ankle to remove, that whole saphenous vein. And we could use that, all right? The only thing is, the saphenous vein has something in it that arteries don't. Veins have something inside of them that arteries don't. What is that? Yeah, valves, right? So when you take that, they'll take the whole thing out, and then they'll look at the whole saphenous vein. You don't need the whole thing, but they're going to pick out the best part to use as the bypass. But when you take this out, you got to make sure that when you put it over here, you reverse it so that the valves are not, you're not going to go against the valve. Right? I wouldn't ask you that, but that's, there are valves in there. So that's what they do over here. You could also use the internal mammillary artery, which kind of gives blood supply to the ribs and then the other part of the chest. But it's right there, so they just kind of, I'll show you, it kind of clips it off and just brings it right where the bypass is. Or we're going to just use some kind of synthetic kind of tubing that pharmaceutical companies make. So what's happening here is that if the coronary artery, there's a blockage over here, bypass, that's what this green thing is, from here over to here. So now the blood flow will go through the bypass. Does that make sense? So it won't go through here because there's a blockage over here. Or we could take the mammillary, internal mammillary artery that's sitting right next to the heart. Blood flow is going through there, our arterial blood flow. So we're just going to clip it off to the where the branches of the ribs go through. No biggie. There's a lot of anastomosis going on, so there's other ways that blood flow can get to the ribs. So we're going to use that and bypass it here if we have a blockage over here. If we do 2 of these, we call it a double bypass. If we have 4 of them, we call it a quadruple bypass. That's all that means. We're just bypassing blood flow away from that, where that occlusion is, right? Wherever that blockage is. So we're bypassing, just the word what it says. Well, remember, we have to sew over here and sew over here. This could get very tedious. So doing, let's say, a quadruple bypass surgery, that could take like about 4 hours to do. And they have a special machine that works like a heart and lungs. So while they're doing the surgery on the heart, the blood is being bypassed in this gigantic machine to get oxygen and whatnot, and then go back into the bloodstream so that there's no blood going through the heart. Otherwise, blood will be pouring out of here, right? So they do that so they have this little bypass machine doing that. Okay? Questions about cabbage? Okay? All right, so what's the prognosis of myocardial infarctions? Well, 25% of mortality rate in the first month. So in other words, if someone has a heart attack, 1 out of 4 people will die actually in the first month, the first 30 days. The remaining people, 10% will die in the first year. Okay, so that's what this is. Like I said, half of the people who die in the first month usually will die from arrhythmias when they're coming to the hospital. Okay? Questions on that?